I was a consultant here since 2017. I did take a short hiatus last year, but I'm now back, and I'm delighted I'm back. And this is a talk I gave pre-COVID to some new starters with a few tweaks, and to the TVN team. It's basically an overview of the sarcoma service. It's not hugely in-depth cancer, but there are some gory wounds, there are some intraoperative videos, so if you are of a bit of a nervous disposition or a bit of a fainter, well, you're sat down, so it'll be all right, so you'll be fine. What do we do at the RH? This is me with one of my oncology fellows. So I spend 2/3 of my time doing bone and soft tissue cancers, in particular sarcoma. You may not know, but this is the largest bone and soft tissue sarcoma unit in the Western world. I say that because we should be proud of it, and I also say that to my patients because also it can take the sting out of the situation. Gabriella, my new fantastic CNS nurse and colleague, Nurse of the Year last year, I understand as well. That's what secured you the job, no doubt. Will often hear me say this to patients because they come to us with very nervous, often with a very bad diagnosis. But understanding that you may have something rare, but we know how to make it better, can often take the sting out of the situation. So we do about 200-300 of these things a year, endoprosthesis. I seem to develop a real interest in soft tissue sarcomas and working closely with my plastic surgeons, and not least this morning. My case is still on the table. Luckily my bit's done, Joe, it's all fine, but the plastic surgeons are covering the hole I've made. I enjoy working across all the specialties, not least with my plastic surgeons and vascular surgeons, but my nursing colleagues. So it's a great place to work, and as I say, it is the biggest centre of its kind in the Western world. So a third of my time is doing things I don't necessarily need to engage my brain too much, so knocking in hip and knee replacements, and doing some odd occasional revisions. We make huge strides to try and not only improve patient care on a day-to-day basis, but to improve the world literature. And it gives you great pleasure when you stand up in a conference and say you're from Birmingham, because we are respected around the world for the tumour service. And we produce between 30 and 40 research papers a year, some of which are in this talk, based on caring for our patients. First picture, warning shot. So this is a sort of routine type of operation. This is the whole humerus coming out. So that's me and the fellow looking pretty chilled at the beginning of the case. And this is a sort of the end result of the case, a whole humerus coming out for an osteosarcoma. And that's what would go in. So that's an endoprosthesis of the upper limb. We haven't got any upper limb here, I'm afraid. We've got some lower limb to pass around later for you to look at. So it does give you a very unique perspective, because this is an elective hospital. It's an orthopaedic hospital. So we seem to, we should be forcing through routine hip and knee, shoulder, foot and ankle. But these patients are an interesting breed. You form very close relationship with them. I'm not saying my colleagues don't care about their knee replacements, but you care about somebody who sits in front of you, and that could be your mother, your father, your brother, your sister, with a bone or soft tissue cancer. And I enjoy the backwards and forwards banter sometimes with them, and that banter can extend often into the theatre. So this is the arrow on the patient's leg to operate on the thigh, and that's just a little warning shot that they better not get metastasis before we operate on them. So this is my patient. This is someone who had multiple operations under my friend and colleague, Professor Grimer, and I was actually amputating their leg because their endoprosthesis at 12 years really wasn't helping them, and they elected to have an amputation, and they were still delighted I was doing it for them. So it does give you a very unique patient cohort and also a unique perspective. So a bit of basic science. So what is a sarcoma? So and what does a tumour mean? So tumour doesn't mean to say cancer. Tumour just means an overgrowth of cells. So most tumours are benign. They're not necessarily cancerous. Cancerous means it can spread. For those of you who did a bit of classics, so sarcoma is basically from the Greek, which means a fleshy growth. So our patients with a sarcoma have a fleshy growth. Maybe soft tissues and maybe bone, but nevertheless have a fleshy growth. But when things become uncoordinated growth, when the cells are run out of their cell cycle, that's the when they become malignant. And malignant means that fleshy growth has the potential to spread. It's a cancerous growth, and they can spread, and that term's called metastasis. So sarcomas are not carcinomas. So carcinomas are the much more common solid organ disease. Lung, breast, skin, bowel, prostate, yada, yada, yada. Sarcomas arise from connective tissues, so bone, ligaments, muscle, fat, cartilage. They grow rapidly, sometimes incredibly quickly. They're very aggressive, but tend to obey normal tissue planes. So I'll show you some pictures of these enormous things pushing out of the leg or the arm, but they tend to push against fascia. So they push the tissues away rather than necessarily invade the surrounding tissues. They can spread, so as I said, because they're a cancer, sarcomas, they metastasize. And they tend to metastasize, not always, but to the lungs primarily. So that's why when we stage people in the oncology unit, we stage their lungs primarily. Depending on the type of tumour, we may also stage other bits of them, like their bones or other soft tissues. But they require very aggressive treatment. Not only do they require often very specialist radio and chemotherapy, they obviously require people with knives and surgeons to do quite specialist surgery on them. So as I say, just to recap, they can come from any tissue, any connective tissue, so bone, cartilage, fat, muscle. So this is a big liposarcoma, this is a big osteosarcoma. So this has come from fat, this has come from bone. So it's connective tissue cancers, as opposed to solid organ, the much more common lung, breast, those sorts of things. So what's the issue with that? Well, actually understanding the terminology is important, but understanding how rare these things are. So there are 59 million people living in the country per year. Only about 400, 450, 500 people will get a bone sarcoma. Working in the sarcoma unit, it feels like everybody's got a bone cancer, but they're incredibly rare. For soft tissue sarcomas, for instance, out of 59 million people in the UK, 2,500 people per year will have a soft tissue sarcoma. And yet we've all got funny lumps and bumps and growths. Not meaning to say I'm paranoid, but much more common to be benign lumps, much rarer to have the soft tissue cancers. Bony metastasis from solid organ carcinomas, so lung, breast, renal, skin, that spread to bone, really super common and increasing day on day, year on year, week on week, because patients with carcinomas live a lot longer and therefore the chance of getting bone spreads a lot higher. So this number increases every single year. So the burden of work for the RH is not just bone and soft tissue sarcomas, but also we look after an awful lot of patients with spread of solid organ disease to bones. It's what we call metastatic carcinoma. So are we good at it? So we know it's very rare, but are we good at detecting it? The sad thing is we're not. So not us personally, but the country in particular and the world in particular. So the take-home message is the average size of a breast carcinoma at diagnosis is actually less than 2.5 centimetres. It's about the size of a 5p piece now. Because if somebody goes with a breast lump or a testicular lump or PR bleeding, it's an automatic 2-week wait referral. If somebody goes with a lump or a bit of knee pain or a bit of hip pain, often that can take an awful long time before the right imaging is done and the patient's referred to the appropriate service. Hence, patients tend to present to our unit late. So the average size of an osteosarcoma is about 12, 13 centimetres. That's a big Ewing sarcoma of the femur. That's 20, 30, 40 centimetres, that's huge. So why is that important? Well, it's important because the smaller they are, the easier to get out and the better chance of survival. The take-home message from this is that those people without metastasis are much more likely to be alive at 10 years. As opposed to those people who present with a metastasis, it's almost certainly a death sentence. And again, it does depend on the type of cancer. So chondrosarcomas generally last a bit longer, but essentially those with metastasis, their overall 5-year survival is basically 50-50%, or 50-50. So it's very important that we try and pick these things up early, by we I mean the external community, and refer patients in appropriately. So as I said, size is important in pretty much all aspects of life, but it's because the larger the tumour, the increase the chance they have of having metastasis. As I said, metastasis is the thing that kills the patient. The tumour that's spread to the lungs or the bones or elsewhere. And because these things present so big, 20%, so 1 in 5 of our Ewing sarcoma patients will have metastasis at diagnosis. It's devastating. Most Ewing sarcoma patients are under the age of 20. Osteosarcomas, 1 in 10 patients will have metastasis at diagnosis because they present at 12, 13 centimetres in size. Soft tissue sarcomas, variable, and chondrosarcoma is a bit lower. But essentially, the larger the tumour, the bigger the chance of metastasis, and therefore the chance of survival falls. And again, the chance of cure according to size, this is all things being equal. So if I've got a 5 centimetre soft tissue sarcoma, it means my surgery is easier, it means the reconstruction is easier, it means they need to use a Steeler vac or have my TVN colleagues look at this wound incessantly for the next 5 weeks, is much lower. But also, it's more important for the patient, not necessarily the morbidity of the surgery, but the chance of survival is much, much higher. Whereas when they present later, much bigger sarcomas, their chance of survival 5 years is 20%. So if the bigger the tumour, the harder the operation, the lower the chance of survival. So how do they present? So soft tissue sarcomas are often painless. So just because you've got a painless lump, is that reassuring? No. Things that increase in size, they can increase in size rapidly, but they can increase in size quite slowly, instantly, over 2, 3, 4 years. But anything getting bigger, anything that's a lump, should be considered to be possibly malignant until proven otherwise. Because what we don't want is something that big in the back of an arm and something growing out of the leg. So the average size of a soft tissue sarcoma diagnosis in the UK, before a few guidelines, which I'll go through in a second, were published, was the size of a baked bean tin can. So that's already bigger than 5 centimetres, that's about 14 centimetres. So we know the chance of survival is lower, the type of morbid surgery we have to do is much greater. So why is that? It's because it's so rare. So the problem is, the average GP or the average orthopaedic surgeon or general surgeon or practice nurse or community nurse will not see a sarcoma. So in particular, the average GP will see one soft tissue sarcoma in their 25-year career. The average GP will not see a bone sarcoma in their whole career. So my friend, colleague and person who got me into this game, a guy called Rob Grimer, published these guidelines along with the University of Leicester around 2006-2007. And these are national guidelines that are in every GP practice, they're in every secondary care practice, and should stimulate someone, the practitioner, to refer that patient for investigation. And it's any lump bigger than 5 centimetres. Any lump that's increasing in size, any lump that's painful, and any lump that's deep. So that's a huge number of lumps, yeah? So that's why we now have 8 consultants working in the orthopaedic unit and the oncology unit, because we get so many patients referred to us. And it was the start of these guidelines in the UK by Rob and other surgeons around the country that really sort of spread the word of sarcoma. And Grimer in particular, I've still got it in my car, bought a load of golf balls and stuck sarcoma on golf balls and sent them round to a bunch of GPs in the region to try and stimulate. If that lump is about the size of a golf ball, i.e. bigger than 5 centimetres, anything else is irrelevant. You need to scan it and try and make sure it's not a sarcoma. Does that make sense? So these guidelines are very broad. The idea is to pick patients up earlier so our surgical insult's lower and their chance of survival is higher. So why was that? Well, Rob started to look at this, and of course he's now retired, but he was a consultant from about there-ish until about here-ish. But the average size of a sarcoma hadn't changed a great deal in his time of his career. He did loads of great things, like fantastic man. But why wasn't the size of sarcoma presentation reducing? Because people didn't know about it. So the guidelines I'll show in a second, the guidelines were there to try and put at the forefront of people's minds, it's not just a lipoma or a ganglion until you've proven it's a lipoma or a ganglion. So any lump, cop a feel of yourselves later in the shower if you wish to feel your lumps, but any lump bigger than 5 centimetres should be thought to be a soft tissue sarcoma or bone sarcoma later, girls, not now, later, until proven otherwise. So we want to prevent this. So this is one of my patients. So you can see how, this is one of my patients from my little sabbatical I went on for a few months. So you can see how, and I've got a very large head. That's clearly bigger than my head. Yeah, so that's enormous. How can someone leave that? Because they trust what people say. They trust this is going to be a lipoma. And in fact, this has grown from very small to about this big in the space of 8 weeks. Yeah, so the surgical insult for that is enormous. So think golf ball. Okay, so let's go back to the RH, and so who looks after these? So we're so cool and we're so big and we look after most people, but what other regions, what other hospitals are there? So there are 5 bone tumour centres in the country that are allowed to look after bone sarcoma. And in the UK in particular, it's not quite the same with the rest of the world, these are legally, financially, from central government, we are duty bound to care for patients with suspected bone sarcoma. And there's Birmingham, Stanmore in London, Oxford, Oswestry and Newcastle. So those are the 5, and out of the 5 are ROH and RNOH, the one in Stanmore, are by far and away the biggest. So there are 5 bone sarcoma centres. And then each bone sarcoma centre also looks after soft tissue sarcomas, and then around the country, depending on the political landscape, there's about 18 soft tissue sarcoma units. The reason being, because there are more soft tissue sarcomas than there are bone sarcomas. So there are about 500 bone sarcomas a year, therefore you only need a few hospitals that specialise in it. as opposed to soft tissue sarcomas, 2,500, so you need a few more hospitals. But pretty much every district general hospital will have a unit that looks after breast cancer, bowel cancer, lung cancer, because they're way more common than sarcoma. So that's why it's super specialist. So the areas for improvement is about trying to get diagnosed early. So we want to heighten awareness. We want to heighten awareness in primary care and secondary care. We want to raise awareness with patients so they don't just get not fobbed off, but just be told by someone it's nothing to worry about when the patient is worried about it. Because what we want to do, as I say, is prevent something like this turning up to clinic, and we want something that small. So the service aims, and this has changed, and it very much depends if it's NHS plan or which government's in power, and next year there'll be a slight different voting system, and Joe's looking forward to a new government as to what happens then. But nevertheless, the idea is to try and improve the outcomes for sarcoma nationally. As I say, this is relatively unique to the UK. So what's happened? So certainly when I was born, 1980, 81, to now. So there were no specialist centres really in the early 80s, late 70s. There was no chemo radiotherapy for these patients. They pretty much all had an amputation and 90% of them would die anyway. So now we have specialised centres, we have specialised surgery and specialised chemo and radiotherapy. We can try and improve the overall survival. So we now have specialist sarcoma centres and a specialist sarcoma MDT in particular here. The reason for that, as I say, the average GP will see one soft tissue sarcoma in their whole career. The average orthopaedic surgeon may see one bone tumour every 5 years. So they're so rare. So from 2006 onwards, Rob and his colleagues got together to write guidelines to try and improve the outcomes. The reason being, as I say, these are rare tumours. And it's important they're managed in a unit where it's not rare. So you know what you're talking about. Your pathologist sees it all the time. Your radiologist knows what they're looking at. Your surgeon knows how to operate on it. And you have an oncologist who knows the drugs to give these patients. The idea is to try and have a consistent outcome across the whole country to try and improve these patients' outcomes. And there's been several different varieties of guidelines published, as I say, the original in 2006. So when Rob was about to retire, he wrote the last of his big guidelines, and we still keep publishing. But these are on the internet, and it's a guide to all centres around the country. The workload for the tumour unit here at the RH, well, as I say, about 58, 59 million people in the UK, I mean England, Scotland and Wales, and a couple of people in Ireland. But the RH covers, depending on where you put the boundaries and where we're getting our referrals, between 25 and 28 million people for the bone tumour service. We get 4,500 referrals a year into the bone tumour service. And we have 11, 12, 10, 9, 8, depending on COVID. We have several operating lists a week. And like my list today, I can get an extra list if I've got an urgent patient who needs an operation. And we have the biggest database in the world of bone and soft tissue sarcomas. Hence, why we have people visit us from around the world. So pre-COVID, we have lots and lots of visitors. At the moment, for our fellows, we've got a Jordanian, an Iranian, a Filipino, someone from India, and then from August, we're getting a real eclectic mix of people to visit us from around the world, because it's not quite so centralised around the world. The volumes people look after are not the same as us here, so they come here for specialist training. So as I say, the numbers of soft tissue sarcomas and bone sarcomas haven't increased a great deal over 20, 30 years, but the numbers of referrals into our unit have increased. Hence there's now 8 of us who do this, as opposed to when Rob was here, 3. Because there's so many more patients who get referred in that we've got to get through all of these patients and see them quickly. So the core team, and this is very variable, and I apologise if I've left some people out. I think that's now more sarcoma nurses, but I'm not very good at counting beyond 5. But we have lots and lots of people to make sure on a Tuesday when we're in our sarcoma MDT that these patients are seen, processed, scanned, biopsied, diagnosed and operated on quickly. The idea is to improve their outcomes. So this is a snapshot of, the referrals from around the country for the last, I think it was 4 months. Obviously we get more referrals around the sort of central area, but essentially we get referrals from Ireland and of course some international referrals for second opinions. So you can see why the tumour units in particular, and that's why Tuesday afternoons clinics in particular are often extremely busy. As I say, Rob wrote his paper and wrote the guidelines, but have they impacted things? And what have we done as a hospital and as a unit to improve the outcomes for patients? Well, we've proven that Rob's work for 25, 30 years, amongst lots of other things, have improved patients. We now know the guidelines that he wrote through NICE means patients are getting referred to us earlier. They're getting referred to us and diagnosed at an earlier stage, which now means their surgery is far less morbid and their chance of survival is better. We've also seen a regional variation reduce. We used to see Wales historically would do worse because they were referred to us later. But because of these guidelines, because of national awareness, we've proven actually the regional variation is also reduced. What's happened to those who've had an inadvertent excision? What we colloquially term as a whoops excision, where someone's cut into a lump thinking it was benign, a ganglion or a lipoma, and then read the path report and gone, a whoops excision, because it's a sarcoma. And what they've done is cut into it, and therefore potentially spread and contaminated those soft tissues. I was amazed when we wrote this paper, because pre-2007, 30 to 40% of referrals to the ROH were inadvertent excisions. Someone somewhere else had cut into it. So I went through this data twice with Tomo, who's now a consultant back in Tokyo, and that can't possibly be true. How on earth? And that's pre my time. And Segi was like, no, this is exactly what happened. A third to 40% of the MDT was flicking through someone's referral and they'd already cut into it by mistake. So the ROH's work has also reduced the number of whoops excisions that we've seen in the ROH. So from that, because we're so busy, this is unique to the ROH. We now have a daily MDT. So we have a Tuesday MDT where we discuss all of our cancer patients on a Tuesday morning. And then every day or every week, one of us is on call, called the COW, the consultant of the week. It was going to be called the consultant on call, but it's a slightly odd set of letters. Although some people, they're deserving of that, an acronym. But the daily MDT, so we have a Monday, Tuesday, Wednesday, Thursday, Friday, bar coronations and things. We have an MDT every day because we have 4,000 referrals a year. We need to vet all of these patients. We need to see their scans. They need a specialist radiologist, a nurse and a surgeon to look through these scans and triage them quickly. And as I say, this is unique to the ROH. And in fact, it was shortlisted for an award a number of years ago, and I think we all went up to Manchester a few years ago to try and win, and I think some hospital in Stoke won an award. But nevertheless, the idea is to try and improve and stratify the pathways because we get so many referrals. And as every single day, up in the radiology unit, at 8:30 in the morning, we go through all referrals for the day before. And has that worked? Yes, and we've proven it. So we've written the paper on the daily MDT. We've proven actually, okay, so we get 4,000 referrals a year. Pre having the daily MDT, we'd see them all here. We'd scan them all here. They'd all have an outpatient appointment. That's an enormous burden. Now we have this daily MDT. We now know 25%, so nearly a quarter of patients can be discharged with a telephone call to reassure them without ever needing to travel to the ROH from Hull, from Manchester, from Scotland, from Ireland. We can discharge them early. We've also proven by having this daily MDT, because we see the scans early and we triage their referrals quickly, their time to diagnosis has dropped by a week. So as work from the ROH, we see more, we process more patients, we diagnose them early, so hopefully their survival is better. So this is a surgical hospital and I'm a surgeon, so let's talk about operations. So as I say, pre-1980, early 80s, without chemo and radiotherapy and sophisticated surgical techniques, patients with amputations, and they would almost certainly invariably die. Now we have sophisticated oncological management, chemo, radiotherapy, and now rather sexy metalwork and surgeons who can take tumours out. Most people can undergo something called limb salvage. So we have sort of two broad categories of how to manage a bone or a soft tissue sarcoma. One's an amputation, and the other is a phrase called limb salvage. So limb salvage means we're taking the tumour out with as clear margin as possible and reconstructing what we can. And 85% can retain their limbs. There's 10-15% of people who, unfortunately, the tumour is so big or it involves too much tissue that we can't do that. But the ethos has changed over the last 30 years because things have improved. So the modern era is that patients with bone sarcoma in particular would get chemotherapy. So the old era, 90% amputation, 10% die. Now, 90% limb salvage, 70% would stay alive because we can give them chemotherapies. We know actually the long-term outcomes of keeping arms and legs not only psychologically are better for the patient, but also has better impact on the quality of life scores. And we know that most implants, and another paper Rob wrote before he left, was on the extreme long-term survival of endoprosthesis. And these are the things that he was designing on the back of a fag packet in the mid-80s in a car park. Those are the first generation implants, not these really fancy implants. And we know 40-50% will survive 20 years. The first generation implants. These things are fantastic, the new stuff. So this is a routine distal femoral replacement. So we can keep the leg, we can reconstruct the bone defect, and the patient can survive. What does that really mean in terms of health economics? Well, okay, so an amputation initially is actually quite cheap. Whereas if we're doing something like this is the best part of sort of 9-10 grand. If we're doing something a custom made for a very particular patient, they can be incredibly expensive. So the outlay initially for limb salvage can be very expensive. But over the lifetime of that patient, the cost equates out such that an amputation is much more expensive. Not only psychological for the patient, not only sort of disfiguring for the patient, they find it difficult to work, they may find it difficult to look after their kids or go to drive a car, and they have to have their prostheses, this plastic leg or this plastic arm, refitted every few months. So it's extremely expensive. So keeping the arms and legs on is very good for patients, obviously, but it's also cost effective. So we do lots of biopsies here. So this is the American Rob Grimer. This is a guy called Henry Mankin. But wrote a lot of information about when to do a biopsy. So we pretty much, because of sophisticated MRIs and CTs these days, we can kind of tell straight away from a scan, are we worried about it? But we still biopsy an awful lot of benign stuff to be absolutely certain we do not miss something. So we always basically, the mantra is before you be blamed for not doing a biopsy, before you forget or we are not allowed to cock this up. So we end up doing an awful lot of biopsies, so a lot of patients you see in the clinic aren't going to convert to cancer, but we need to prove they weren't cancer in the first place. So that's why we have this whole team of people, including biopsies, to reduce that chance down. So the interesting thing, so who should do a biopsy? So I can see one of the two of the registrars here. So this is a very standard thing they get asked in the exam. Who should do a biopsy? So the standard mantra they get drummed into them now is they've got to be done in a tertiary centre, must be referred to Birmingham, must have a needle biopsy, must be done in a proper hospital by a surgeon with experience. But actually out of all of this, it's the one doctor the patient doesn't see, the pathologist. So there is only about 17, 18 sarcoma surgeons in the country. There are less than 7 bone sarcoma pathologists in the country. So most biopsies done elsewhere, well not most, sorry, a third of biopsies done elsewhere will be an incorrect diagnosis. So they may say it's benign and it's actually cancer. That's really bad. They may say it's cancer and refer it in and it's benign. Well, that's not quite so bad because we can say it's not cancer. But a third of biopsies done elsewhere, it's not because the pathologist in the hospital is incompetent, it's because they're not used to looking at this tissue. It's extremely rare. They haven't got the right tests. So as I say, it's important to have this centralised process for sarcoma to get the diagnosis right. So a third of biopsies done elsewhere are incorrect. And for our patients, that also massively delays their pathways. Sean and the rest of the oncology unit are constantly trying to fight fires to get these patients into our building quickly because they've had a biopsy done elsewhere. Is it right? Is it wrong? And we get them on week 4 of their referral pathway. So they're hugely delayed. So the reasons why we tend to centralise and see patients and the success of the daily MDT means we stop someone cutting into it, we get them referred early, we stop other hospitals biopsying it, we can either see the patient early or discharge them without ever seeing them to try and stop this from happening. So how do we do biopsies? So there's multiple different ways of doing biopsies. This is a standard bone biopsy. So bone biopsies these days are essentially all, bar a few, done in the CT machine. So what would routinely happen, we'd see the patient would be referred on, say, a Wednesday. We'd see the patient at a DMDT once we've got all the scans on a Thursday or Friday. We'd then see the patient in the cancer clinic on a Tuesday. They'd be biopsied the following day. So they get this one-stop shop type service to try and speed up their process. When I was a registrar, pretty much all biopsies were done in theatre, and it was a real heavy burden to try and find theatre slots. But again, the success of the service means not only does the tumour service and surgeons grow, it means the nurses can grow, it means the backroom staff can grow, but also means TVNs get employed, the ancillary services that we need to use to look after our patients can grow, but also the radiology departments grow. Because the gold standard actually is not us blindly sticking needles in bones, it's for the radiologist to use a needle and guide that needle into the bone, or guide that needle into the soft tissue using an ultrasound machine. So this is just an example of an image-guided bone biopsy for a tumour affecting the humerus. So multidisciplinary teams approach is essential. I put this on there, I'm deliberately not on there. So that MDT now is about, when was Andrew in that dress, Anita? It's probably about 09. So, and now Mr. Grammer's retired, Prof. Klingbaum's retired, Roger Tillman's about to retire. Segi always looks like Segi, God knows. Where's Lee with his full ginger hair? There he is there. So that's now grown massively. There's loads of us as part of this MDT. But it's super important to have all of those people together. All of us pulling together to try and improve the outcomes for these poor patients who've got dreadful cancer. So a little bit about margins. You might hear us talk about margins. So we get these tumours out, and it's not about popping them out like a pea or popping them out like a lipoma. When we talk about margins, we've got to get this cancer out with as clear margin as possible to not leave any cells behind. So yes, we have all of these fancy x-rays and bits of sexy metalwork. That's the easy bit of the operation, gluing these things in. The hard thing is dissecting arteries and vessels and nerves and taking stuff out that needs to come out and leaving stuff in that needs to stay in the patient. And this is all about margins. And when it comes to cancer, we need to resect tumours with a clear margin. So either with a wide resection through normal tissue. Most of the time these sarcomas are so huge and next to vessels or nerves, so we go through something called a pseudocapsule. So that's a marginal resection. A radical resection, and I'll show you some pictures in a second, is a whole compartment comes out. And then beyond that, of course, it's an amputation. So as I said right at the beginning, the reason why we can take these things out and can keep arms and legs on is because we now know the biology of sarcoma. They grow quickly, but they respect fascial planes, generally speaking. So they'll push into fascia, they'll push against bone for soft tissue, or they'll push into muscle, but they won't necessarily invade through it, invade through vessels. So if this is a soft tissue sarcoma, I know I can come in around here, peel this muscle out, keep the fascia, peel a line of the bone, or indeed take a section of the bone out, but keep the leg on. We don't need to take the whole leg off. So understanding how these tumours grow and understanding the biology has hugely improved not only the surgery, but also the outcomes for patients. So normal tissues like cartilage and lining of bone called periosteum and lining of muscles called fascia are very good boundaries. So we spend an awful lot of time, and my 4 hours this morning was spent peeling off this femoral artery to peel off the fascia, to keep the artery in the patient, and to put the fascia on the tumour and use that as a boundary. So the leg stays on and the tumour comes out with a clear margin. So the next sort of 20 minutes, half an hour's bit of the talk, there's a bunch of gory pictures. So we're going to break it down into soft tissue sarcomas and then metalwork, which is basically bone sarcomas. So we've said there's 2,500 soft tissue sarcomas. There are about 50 different subtypes of soft tissue sarcoma because there's different types of muscle, there's different types of cartilage, there's different types of ligament, and all of them have their own name. Most soft tissue sarcomas will have surgery, and some will have other treatments like chemo and radiotherapy depending on the type of sarcoma. But they should be managed in specialist centres for exactly the reasons I've talked about. So this is a soft tissue sarcoma I did before I went away. So the reason why these patients are operated on here, this is the size of, and I like to grade things according to fruit, this is an avocado-sized mass, but it's superficial and growing out. And yet, an avocado-sized mass, I've had to take the whole half of this patient's thigh on the lateral aspect off to get clear margins. What am I pointing at? That's a sciatic nerve at the back of the leg. So all of the fascia, layers of muscle and skin have been taken out to get this a clear margin. As opposed to if this was a lipoma, 5 centimetre incision and pop it out like a pea. So the reason why these patients get referred in is, of course, as I say, it's for specialist surgery. This is a compartment. Another one of my patients says, how the hell can he leave this to get so big? Because it grew over 2 months. And he saw his GP at week 3, when it was about that big, he's reassured, and then when he's really poorly, he gets referred in and it's this big. So I haven't got the MRI, because it was beyond my capabilities to show you an MRI running, but needless to say, it's the whole quadriceps, the whole quadriceps. So how do we get this out? Well, this is my lines on there, sort of line of faith to how do I get this out. So this is the whole quadriceps. So that's the foot, knee, hip, tummy, ghoulies covered. So the whole thigh. So in the old days, this patient would have an amputation and there's still a good chance of dying. But now we know fascia is a good barrier, periosteum is a good barrier, the lining of nerves and vessels are a good barrier. So how we earn our keep, and there's a tumour surgeon, is we peel all of these things away and try and keep things in the patient. So this is the whole quadriceps come out. So I've gone from the groin, and on the video, this is the artery all the way down the leg that's beating. The whole femur has been filleted. And the only muscle that's left on the front of the thigh is something called sartorius. So we know this lining of bone here, the periosteum as on this. We know the skin and fascia are a good barrier. So I've been able to get this whole thing out with clear margins and keep the patient's leg on. But you can see why we not only now do we have these fancy surgery, but we've got these huge wounds to deal with. So to come a bit full circle, a bit early, this is why we not only do you need surgeons to take these out, this is why having the ancillary support from people like tissue viability teams, infection control teams, so when I put this together, it's got the best chance of healing. This is what happens when you have an inadvertent excision. So this patient had a golf ball size mass on the front of their leg that was excised by a plastic surgeon in the West Midlands. Beyond me why they did it with 3 incisions, but they've shelled it out like a pea, and this was a soft tissue sarcoma. So all of this area is now contaminated. What I could have done is just done that, and what I needed to do is this. So you have to peel away all the muscles or the fascia of the anterior compartment, peel all the deep bit of bone and the periosteum of the tibia, and peel all the fascia of the posterior compartment, because they'd had an inadvertent excision. So the morbidity of the surgery has gone up for the patient. This has now been reconstructed. This is why I keep my plastic surgeons busy. They've now got a flap, so muscles now covering the bone, and this is a skin graft. And again, as our orthopedic knowledge and expertise has gotten better, we've now got 2/2.5 fantastic plastic surgeons who we now work very closely with. And these wounds need specialist management. Hence we have nurses in Ward 3 who are used to looking after these sorts of patients, and we've got even specialist people that are tissue viability nurses who I think nothing of, and they don't mind me at all, knocking on their door, dropping them an email and going, look, I've done this, I want this to heal. And it's really important we have this expertise in this building, because it isn't just me, it's all of us who makes these people better. This is an arm. Well, okay, so you've got a big thing in the leg, so okay, but the leg's got a bit of space. How do you save an arm? So these are my 8.5 gloves. In fact, that's my hand, that's Niall's hand, one of the registrars. You'll be able to tell that's Niall's hand if you know Niall. So this is a huge tumour affecting the flexor compartment. How on earth do we get that out and save the arm and make it heal? Because what I can do is then strip the whole arm. So this is why they get operated on in a specialist centre. So just orientate you. This is the elbow. That's the radial head. That's the elbow joint. That's the biceps. I'm pointing at the radial artery, which has been filleted all the way down to the wrist, because the blood's got to get from the heart to the hand somehow. This is the radial nerve, which has been filleted all the way down. And then I've deliberately not put the photo on of Deb Fong rolling her eyes as I showed her this. So this is Miss Fong, who's then done a free flap. So not a local flap. This is skin, fat and fascia taken from the leg. So this is taken from the patient's contralateral leg with its blood supply. So this tissue here is an artery coming from the fat and fascia from the thigh and being plumbed into the artery I was managed to save in the arm, and that's what it looks like at the end. But of course that's what it looks like at the end. Does it look like that in 2 weeks? Well, it requires the patient to behave themselves, drink that protein drinks I prescribe them, eat that food I tell them to eat, drink the water. And a phrase I'd often use again to patients is, look, I know this is awful. You are allowed to feel sorry for yourself. This is really bad. But you're not allowed to feel sorry for yourself and not eat and drink, because this won't heal. So the patient's got to buy into this. This is a team effort. And again, this is where my colleagues in tissue viability will be getting a phone call and an email to make sure this heals. Because this is a free flap. This is incredibly morbid for the patient. So it's got to heal. So as I say, another example of why these patients require expert surgical management, not only from the surgeon, but from the hospital as a whole. So any questions on that so far? So then we operate on them. So what happens to these patients? It's very intensive. So as I say, centrally from government, we get paid, not me personally, but the hospital gets funding to not only to diagnose, manage, but also look after them long term. So the follow-up's very intensive. Hence our clinics on a Tuesday are busy. Mine yesterday in particular. Apologies, Gabriella, you finish at 7. So they get followed up every 3 months for 2 years. Then every 6 months for 5 years. And then every year up to year 10. And when you've done your year 10, you're out of Shawshank. You're no longer in the cancer follow-up. If you've got one of these bad boys in, some metalwork, we never discharge you. Because at some point that will loosen, and at some point it's going to need surgery again. So we never discharge them. Every time the patient comes back, they're often nervous. They're often feeling sick, certainly for the first few years they're coming back. They ignore it, and then the build-up to the clinic comes. The build-up, the worry, the anxiety. And the first thing I do with my follow-ups is go, your x-ray's fine. And then all of this boomph, this anxiety just dissipates from the clinic. I'll also, because you build up a rapport with these patients, and try and work out what else goes on in their life. When are they going on holiday? What's their dog's name? What do they do for a job? What do they enjoy doing? Chloe has to type my letters. But I always write these things down so I remember the next time the patients come back to ask them what happened in Mallorca. Did they enjoy their time? What car did they eventually buy? I was thinking about changing my job. How did that job interview go? Because you know these guys for years, particularly the kids. You see them grow up, hopefully. You see them have their own families, hopefully. You see them go to school. You need to build up that rapport. It's very different than looking after a knee replacement. So they get an examination every time they come back. They have an x-ray of the chest every time they come back to look for metastasis. The reason we examine them is to check they haven't got local recurrence. As I say, if the patient has a metalwork in there, we never discharge them. Because patients have to travel such long distances, and as I say, we cover 28, 25 million people, some of us, the surgeons, have outreach clinics. So I go to Sheffield every 3 months. Mickey Pazza goes up to Leeds. I hate me calling him Mickey Pazza. Please call him Mickey Pazza next time you see him. Seggy goes to Bristol. Steve-O has a jolly in Cardiff, and Lee does Liverpool and Manchester on the same day if he's in the country. So and then we do that every 3 months to try and help us as a unit, so we don't have to follow up all these patients here in clinic, so we can see all the new patients quickly. But also it helps the patients. So I drive up or get a train up every 3 months, and similarly my colleagues go to different parts of the country to care for these patients and look after them long term. All right, and so the last bit is heavy metal. Not Iron Maiden or Metallica, but about metalwork. Any questions so far? Anybody sick? So prosthetics, heavy metal. So EPRs. So if you've not had a chance to have a feel of these things, have a feel of them. So pass one around, Sean, if you don't mind. So Sean on that side's getting a tibia. This is a very short distal femoral replacement. The advantages of metalwork. So we use metalwork and endoprosthesis for bone tumours, obviously. So the bone's got to come out, and we've got to reconstruct the bone. They're readily available. As I say, these are not custom-made implants. This is a very small snapshot of what we got on the shelf. So what we can do, we can go from a simple knee replacement to a total femur, all on the shelf here in the building. We can go from a short shoulder replacement to a total humeral replacement, all on the shelf. Very unique hospital to be able to do that. So they can be modular, so pretty much all the ones are modular. By that I mean they come in different parts and we can build them up to different lengths that we need and build things up. And that's what we've got on the shelf. Or for very special patients, or for patients that their anatomy is abnormal, we may need to get custom made. So custom made is a bit like we go to buy our suit in Marks and Spencer's. That's a modular, off the shelf. As opposed to custom made is you're going to buy your wedding suit from Savile Row. It's only made for you. So the custom made implants are the ones that are made just for that patient. The only one of its kind in the world, the custom made. So those are for patients who, as I say, have interesting anatomy. And the last one of my patients was a patient with osteosarcoma of the femur who's also had a version of dwarfism. So they were very, very small. So those things wouldn't fit. So we got something made. So the beauty of metalwork means you can walk on it straight away or use your arm relatively straight away. It allows the patients to return to function pretty quickly, not necessarily full function. It means also we need specialist physiotherapists and OTs and ancillary support staff who know what to do with these things. This is not just a shoulder replacement. That's not just a knee replacement. These patients need very specialist rehabilitation. And generally speaking, they have a pretty low complication rate. The advantages of the metalwork, as I say, it's expensive straight away. So the off-the-shelf stuff, that's a very short prox femur, it's about $4,500. Custom-made stuff, pick a number, it's expensive. But you do get increasing complications, certainly with time. So at some point, it may loosen. So you can see this bone is loosening around the stem. There's a black haloing around it because the stem's been toggling inside it. Metalwork, just like the metal on your car door, the metal of bridges, or the Eiffel Tower needs to be repaired all the time, it can fatigue and break. So metalwork can break. And the lifetime risk of an amputation with an endoprosthesis is about 10%. And if we're getting patients on with bone sarcoma who need chemotherapy, they have to stop their chemotherapy in order for us to do this to them. Because the chemotherapy obviously means they're immunocompromised. So often you will see patients in our clinic with a full head of hair, all due respect, James, but a full head of hair looking well, and then we see them again, they're cachectic, they're thin, they're anemic, they're bald, they've got a sore mouth because they've had horrendous chemotherapy, trying to get them ready to kill off the cancer cells, and then we can do an endoprosthesis. So what can we replace? Everything. So we can do anything. So we can get anything made. Particularly these days, we have 3D printing machines, not in the building, but we can get things made. So we can place anything. Pick a bone. We can get anything replaced. So, and on the shelf, what we have is everything for the arm, pretty much everything for a whole femur, pretty much most things for a whole tibia. So on the shelf, unique to this place, is that we can bolt together skeletons. So this is a pretty routine distal femur replacement. This is a high-grade osteosarcoma. So you can see there's a big tumour, it's blown out of the bone. It's a young patient because the growth plate's still open. And this is an intraoperative picture. So unlike knee replacements where you cut the skin and get down to bone and stay on bone, in tumour surgery, you don't want to see the tumour. So we've dissected the knee, that's the end of the knee, and all of this is soft tissue covering the tumour. So this is the quadricep mechanism that's been opened. And then we've got to then gradually dissect this out. So this is my fellow at the other side of the table. Gradually, as I elevate the femur out, and the pulsy thing at the back here, I'm not allowed to cut. Occasionally, we run into problems. But we're not meant to cut the artery, and we'll gradually deliver this thing out. So this is the femur that's come out with a tumour, and this is the prosthesis that's going to go in. And this is a custom-made prosthesis because it was a child. So we're reconstructing the skeleton. This is a pretty routine operation in this hospital. This is the prosthesis, I keep on saying glued in, it's not, it's cemented in with clever bone cement. So this is the femoral component, that's the knee component, that's the knee replacement, but that's of course is the metalwork we've used to reconstruct the bone defect. And this is what the patient functions like on the table straight away after the operation. So they survived pretty well, and again before Rob retired, he published some data on what happens to these things. So the average knee replacement will do very well by 10 years for arthritis, but these were a very different kettle of fish, very different patients. So we can kind of predict that proximal humeral replacements will do well, very unlikely to be revised. But when we come down to the tibia has a high revision rate. And the reason being the tibia somewhere is the tibia has very poor soft tissue coverage. It's just skin and metal. So the metal gets infected much more frequently around the tibia because it hasn't got a very good soft tissue envelope. But nevertheless, we're still talking 70% of them are still doing okay by 10 years. You know, so that's better than not having your leg. Growers. So not so much for adults, but for kids. For kids with bone sarcoma, and just to put it in perspective, 450 bone sarcomas a year. Ewing sarcoma classically affects those under the age of 20, usually under the age of 10. Osteosarcoma around the age of 20. So there's going to be some skeletal growth left. So if you put in a femur like this, or a tibia that's going round, it won't grow. So the patient will have a very short leg as the other leg continues to grow. And one of the other advances in endoprosthesis was the ability to grow a leg. So this is a patient who's undergone a distal femoral replacement, and at one point that bit of metal would have been there. But because of the ratchet mechanism, what we can do is lengthen them so the leg can grow. This is what we call an invasive lengthener. This was started again in perhaps mid-90s by Rob, where every time they have to come in for an operation where we make an incision on the side of the leg, open the Allen key and turn the ratchet and watch it with an X-ray, this thing grow, and then lock it back together. So the problem with doing that, of course, is they have to have an operation every few months as they grow. And the risk of the infection goes up because we're looking at metalwork, and metalwork does not like to be looked at. So the next thing then was, well, what can we do? I say we, the clever engineers and Rob Grimer. What can we do to try and reduce the chance of us needing to use Allen keys and reduce the chance of taking the patient to theatre? And then magnets, baby, electromagnets. So we're able to advance the growing technology to be able to use magnets. So instead of a patient going into theatre, a child going to theatre and have an anaesthetic every few months, for us to cut their leg and move the metalwork, they put their leg inside a donut. And this is, again, the surgeon doesn't get involved in this. And this is why we need the specialist services. So, there we go. So we've got our specialist physio team, excuse me. who are trained to look at not only rehab these kids to get the best function from their endoprosthesis, but also are trained to use the donut. So the child will come in, put their leg inside this magnetic grower, and through the power of science, magic and voodoo, the metalwork inside here with the magnet will lengthen the leg. And correct me if I'm wrong, you still put a stethoscope on it and hear the mechanism run. Yeah, listen to it. So you're listening for this mechanism to to feel and hear the leg grow. So that's clearly much better for the patient to reduce the chance of having an operation. They don't have to be put to sleep to have the lengthening, and we don't have to look at the metalwork. So the chance of infection is much lower, but they're really super expensive. So the average cost of a metal grower, magnetic grower, for the mechanism is about 14 grand. And then building everything around it adds more cost. Lengthening, correct me if I'm wrong, is very variable. Some kids tolerate it well, some kids not so good, but it's relatively painless. Patients and parents definitely love it because your child is not needing an anaesthetic. There's been very few, I say no, but very few major problems to date. We've had a couple of them where they've now collapsed, but very few. In the first few years, we had no infections with them because we weren't operating on them, we weren't cutting into the skin. We've now had a few, not because of the magnet, just because it's big metal. But it's pretty much actually very cost effective again. So the cost outlay is very high because they don't get infected. They don't need an anaesthetic every few months. Actually, it's very cheap in the long term. The issue we have with magnetic growers is they can't have an MRI. So if we've got a very tight margin or a tumour where we'd be very concerned for local recurrence, we would not put a magnetic grower in because we wouldn't be able to MRI that patient because the MRI would bugger the magnet. So we then have to go back to the old invasive grower. So navigation. So Rob again, and then Lee's really taken this on. Navigation has been an absolute game changer for pelvises. So what navigation does, it uses very similar technology to what your car will do to be able to navigate you around the place. It means we can get 3D models of CT scan looking at the bone and an MRI looking for soft tissue, and we can map bone and soft tissue in real time in theatre with what we're seeing with our knife and our saw in our hand and overlay the images such that if we're trying to cut out very complex tumours, just to put in perspective, that's the bone tumour, this is the soft tissue bit of the cancer, massive, that's the bowel, that's the bladder. So the whole thing's been pushed and moved. So how do you get that out, understanding the 3D? Well, using navigated resection. So navigated resection means we can get really fancy custom scans to start with. We then know the size of the tumour, and at the time we can then overlay what we're doing with navigated pointers in theatre and map the tumour. So this is us planning. If I put my saw there, I cut into it. If I put my saw there, I cut into it. If I put my saw there, I'm away from it. If I put my saw there, I'm away from it. If I put my saw there, I'm into it. So we can map before we do something stupid and cut into the tumour. We can also map where these big pulsy things are, so hopefully we don't hit them in theatre. Sometimes it works, sometimes it's not quite so effective. But the idea is that we can use the navigation so we can plan. Other things. So if we've got children that has an osteosarcoma, this is the growth plate, so we know they're still growing. But actually it doesn't involve the knee in this patient. So do we need to violate their knee and give them some metal work like you've got on your table? Or can we take the tumour out and protect their knee, keep their own ligaments? About a third of tumours will not breach a thing called the physis. So the physis is the growth plate, and it's how bones, long bones grow. And this is another example of technological advances. Now we can get sophisticated scans, and we are very fancy engineers. We can come up with schematic diagrams such as this. So we can take the tumour out and keep the knee, keep the patient's own ligaments, so it feels like a knee, as opposed to a ratchet or a mechanism like a hinge on a door of like the metalwork that's been passed around at the moment. So what we can do is take the tumour out and affix the metalwork to the skeleton, but protect the patient's knee. Really useful for children, because you keep their ligaments. So intraoperatively, what we're doing is, this is the end of the femur. The ligaments are still attached. We've taken the tumour out using navigation. I've then cut the bone and we're proximal to the physis, and we're getting exact measurements, exact sizing to ensure this custom-made prosthesis fits in nicely. So the patient's got their own knee, but the metal bit that reconstructs the bone is affixed to the patient's skeleton. And that's much better because, as the physios will attest to, the patients have to get used to this new ratchet mechanism if they get a hinged knee. If you can keep the patient's own biology, as in this case their own ligaments, their cruciate ligaments, their knee can behave much more freely. So they can try and break it 8 months later by playing in the park. Because the ligaments, there's absolutely no way a distal femoral replacement will be thrashing branches around like that at 8 months. Because it feels much more like a hinge on a door. Whereas this, because we've got the sophisticated technology now, we can keep the ligaments. So it feels much more biologically normal for the patient. Similarly, because we haven't violated the knee, the tibial growth plate's okay, so the leg will grow. As opposed to with that prosthesis you've got there going round, we'd have to violate the growth plate and make the patient grow every few months. So it's a double whammy winner. So that's some heavy metal. But we also use biological solutions. So we use bone. Not only can we take bone out, we can put bone back in. So bone's good for good prognosis tumours because bone takes ages to heal. Whereas metalwork, once it's in, just works. Whereas bone takes a while. It's very good for very small children. For metalwork that wouldn't fit for 3 or 4 year old. Very good for very difficult to reconstruct areas. So the radius, for instance, or the proximal humerus. So this is an example of a bit of bone we use. This is an allograft. This is a patient's fibula. It's tiny. Look at the size of this. So this is many years ago when I did a proximal humerus section here. This is Miss Fung and one of the other fellows reconstructing the fibula into the humerus. And I'll show you some pictures in a moment. So as I say, donated bone's very good for good prognostic tumours. So this is a Ewing sarcoma of the tibia in a young patient. We've taken the tibia out, but if we put metalwork in there, we would screw up the physis there, and we'd screw up the physis here, so the growth plate, so the growth would be affected. They'd also have metal under skin, and we know metal under skin increases the chance of infection. So what we can do is then rob the fibula. So we steal the patient's fibula and stick it in between. And over time, the fibula grows to look like a normal bone. So again, the beauty of having these services in specialist hospitals is not only to improve the diagnosis on day one, it means that our techniques and our surgical ability improves because we're used to looking after these patients. So as I say, that was the fibula that we took out, and kids are great. Kids just heal and grow. The fibula is a very useful bone to steal. This is an angiogram of the knee, so lots and lots of blood vessels, but this is the fibula bone. And the fibula also has a growth plate. And this is very useful for the proximal humerus because the proximal humerus in a small child is tiny. There's no amount of metalwork that's going to fit in there. And also there's no amount of metalwork we can make fit and grow. So we don't want a child with a very short arm with a bit of metal that's not doing anything. So the fibula is very useful to steal. So this is an example. So this is the patient who, the picture I showed you earlier with Miss Fong on the microscope. This is a patient young because the growth plate's open. This is an osteosarcoma of the humerus. I think there were 5. So this is the MRI scan showing a big tumour, huge tumour coming out of the bone. That's the humeral head, that's the socket, that's the lung, and this is the front view. So the tumour extending all the way down. So there's no amount of metalwork that we're going to get small enough to fit in there. And certainly if we can get some metal to fit, it wouldn't grow. So what we can do is take the tumour out. This is the tumour, that's my hand, look at the size of the arm. So the tumour's taken out, and this is the patient's fibula. So the fibula has been harvested from the patient's leg with its blood supply. I've been able to preserve the brachial artery, and the plastic surgeons have then stitched the fibula blood supply into the brachial artery. So this is now a vascularized fibula. So it's bone, it'll heal, and also the growth plate of the fibula is still there, so the fibula will grow. So not only do they not have metal, but they have bone that will grow. It's very useful for small children. So this is it post-op. So that is not the humerus. That's the fibula. So this is the humerus that's left, and this is the fibula that's been affixed to it. Because kids are crazy and they do things and break their arms, but this is a vascularized fibula. So even if they break it, it heals. So this is the bone healing. So this is callus, the bone forming. And if we wouldn't be able to do that, if it wasn't for be able to look after patients here, increase our surgical ability to be able to give them this type of reconstruction, they would have a totally flail arm. And over time, the fibula will thicken. The fibula will straighten and it will widen and start to look more like a humerus. And it means we've got bone there, so we can stitch muscles down to the bone. We can't stitch muscle to metalwork. So we'll hopefully start to work. So this is the same child, 7 weeks out, still having chemotherapy. attempting to break their arm, but playing golf. There's no way, I'm not saying the golf swing's great, but there's no way they'd be able to do that with metalwork in their arm. So it's very, very useful to be able to have this surgical ability and whole round ability because of this hospital, to be able to try and reconstruct these kids. I put this in because this happened, this is Vanita and I's patient from just before I went away. This is pretty much the extreme thing we've ever done here for a tibia. So this is the patient's knee and the ankle, and there's a thing in this bone here called an adamantinoma. An adamantinoma is an extremely rare bone sarcoma, occurs in about 20-30 people a year in the whole country. But it involved from about the knee joint there all the way down to the ankle joint. So all of that bone's involved. How the hell do you get that out and reconstruct it? We figured out, okay, so this is us dissecting the tibia. So this is the tibia coming out. But because we now have this technological ability, we can get not only just us eyeballing it, we can get patient-specific jigs. So these are jigs that are designed off CT and MRI scans that will only fit this patient's tibia. Will only allow us to cut in the area this jig will allow us to cut. So I can cut the tibia like a jigsaw and peel the bone out, preserve the ankle and preserve the knee. So that's the jig, that's the bone that's been taken out. Because we got some plastic models to see if it would fit like a jigsaw, and it did, apart from that bit down there. It took a bit too much bone, but it looks about right. Far better than what we'd be doing with eyeballing it. So we've now got this big defect to reconstruct between the knee and the ankle. But again, because we work in a specialist centre, not only with plastic surgeons and also trauma surgeons. So what we can then do is put a frame on it. So this patient's kept their knee, kept their ankle, and they've got a growing frame. So what we then did over time is grow the patient's own tibia. So the tibia will then grow the whole length of that defect. So they don't have metalwork there. Once the bone reconstitutes, they've got their own tibia. So it might look rather grotesque, but it's far better to keep your leg and amputate it. It's far better than having donated dead bone with the risk of infection. It's far better than having metalwork in there because of the risk of infection of loosening. So again, because we work in a specialist centre, we see lots of patients with this. We can try and not push the boundaries, but we can use the advances in engineering to try and keep patients' legs and arms going. So allografts, so bone from patients is called autografts, allografts. And allografts have been around for a while and using cadavers and putting them in patients back in the sort of 15th century. They'd all pour out with pus, of course. But allografts these days are basically, allograft is patient's bone that's been donated. They don't need it any longer for various different reasons, and we can put it into the patient that does need it. They're very expensive. They're often hard to find, particularly if you want really something very, very specific. You know, for instance, a whole humerus for a 16-year-old is very hard to find. But they're quite useful for filling big defects. Well, another thing that was pioneered here was not just use of allograft and autograft, but this very fancy thing. Well, okay, we can take the bone out, but we want to use the patient's bone to put back in. So Rob and Seghi and some guys in Italy pioneered this excision of the bone, scrape the tumour off, send the bone off to be irradiated and put back in the patient. Because there's nothing more specific and custom made than the patient's own bone. That will fit them perfectly. Quite useful for hard to reconstruct areas, show the tibia again. And it's quite useful for whole joints. So this is a classic view of an adamantinoma. You get this sort of odd soap bubble appearance on the tibia. This is a cancer. So before the days of excision and reimplantation, we'll be cutting the bone there and there. And this is again before the days of growing bones with frames. What the heck do you put back in here? Well, it could be metal, but the problem with metal, as I say, it gets infected. It can loosen if it's metal. But why don't we use the patient's own bone? So we take the bone out, we scrape the tumour off in a sterile table elsewhere in the theatre. It gets sent off to the QE while the patient's under anaesthetic, and they get a massive dose of radiation, like going to Chernobyl. So there's no way you're going to get 90 Gray. So to put it in perspective, a single shot of radiation is about 1 Gray. Soft tissue sarcomas get 5 weeks of radiation of about 50 Gray. The bone gets 90 Gray in one go. So the whole bone is cooked, not literally cooked, but it gets irradiated so that all the cancer's killed by the radiation, and then it's reimplanted. So this is the tumour on the MRI. This is the tumour coming out. And it gets packed up in a sterile box, gets sent off down to the QE, and gets irradiated. The wound's covered up. We go and have a coffee. The anaesthetist finishes Sudoku, or whatever else they're doing. And then the bone comes back, having been scraped out, and nothing fits like a perfect jigsaw. So this is the perfect jigsaw because it's been taken out of the patient. And then we can fix it to the patient. And now because this is a child, we've also robbed their their fibula. So the tibia's come out, been cooked, and we've put the fibula inside it as autograft. This is something called the hot dog technique. So the bun of the hot dog is the patient's own tibia. The sausage of the hot dog is the vascularized fibula. And in kids, the miraculous thing in kids is over time, the fibula regrows. So if you give it long enough, they have their normal bone. So the bone thickens up, they've got their own bone, and also the fibula thickens up. So once they reach their 10 years of cancer follow-up, because they haven't got any heavy metal inside them, we can actually discharge them. So the beauty of bone, albeit it can take an awful long time to heal, it has to be for good prognosis tumours, but once they heal, it's patient's bone. It's fantastic. It's not metalwork. So what you can often see is actually because they grow and get skinnier, bits of things start to poke out. So we wouldn't routinely take them out. And if we take them out, we often run into problems because they fracture through the screw holes. So we try and keep them in as much as we can. But sometimes, because they fit when they're small and they don't fit now, sometimes we end up either taking parts of the metalwork out, like taking an angle grinder or diamond-tipped cutter, and just going, oh, okay, we don't want to go that scary, but we'll cut this bit off so it's not rubbing on the skin so much. So generally speaking, we wouldn't routinely remove the plate. It's good for whole joints. So a custom elbow never really fits the patient properly. It doesn't feel like a normal elbow because it's metalwork. But how do you replace whole joints? Well, actually what we can do is take the elbow out, radius, ulnar, humerus, elbow, scrape the tumour off. So it looks a bit like a fillet of lamb, I guess. But you scrape the tumour off, all the tumour's gone, pre-plate it, pre-scrape it, and then fix it back in. And the patient's elbow works. Now, this has huge high risks, because of course, the bone may not heal. The bone might get infected. Well, the worst case scenario, if the bone doesn't heal, well, we do an endoprosthesis anyway. But if it does heal, it's the patient's own bone, the extreme salvage cases. So there's a video of a very famous little girl. She's not so little now. But this is perhaps once a year we'll do one of these sorts of cases here. Vineet Krusunkal, who came as a fellow from Tata Memorial Hospital in India. If we think we're big, go to Tata. It's ginormous sarcoma unit. Vineet's probably got more experience than any of us put together of doing this sort of operation. So this is an unfortunate young girl who fell off a trampoline, went to a local hospital, and because it's a broken bone, they fixed it. But didn't quite realise there is a bit of bone missing. So this turned out to be an osteosarcoma. So the problem is once they plated it, because it's bone cancer, all the bone disappears, the screws are floating in the breeze, and all of the soft tissue on the MRI scan is totally contaminated. So there's no real way we can salvage that leg. So in this sort of patient, unfortunately, that would be a very high above knee amputation. But in young patients where limb salvage is not an option, often we can do a thing called a rotation plasty. So some of you guys would have seen a rotation plasty. Some of you may not. So what a rotation plasty is basically we take out the diseased part with or without the vessels, and then so for this person, section that portion of the whole femur. All the soft tissue comes out with the vessels. This is sciatic nerve coming all the way down. This is the patient's lower leg. This is the patient's hip joint. And then what we join is the lower leg to the hip and spin the foot round. The reason for doing that is if we use the ankle as a knee. So the foot's put on backwards. So when they tippy toe, they bend their knee. And when they're non-tippy toe, when they do naughty toes, if you're a ballet dancer, they straighten their knee. So in theatre, when they come round in recovery, their knee is now at their ankle joint. And when they're waking up, you ask them to wiggle their toes, and it's very unusual to see the toes wiggling when the foot's on backwards. So the patient has to be counselled about this. Of course, this is can be visually displeasing for patients. You have to be quite mentally tough. The patients often, as I say, are young, because young patients are much more robust at coping with this. But the beauty of doing this is the foot is sensate. The foot fits into a prosthesis perfectly. And when they're walking, particularly with baggy dresses or baggy trousers on, you wouldn't tell they've had an amputation. So what we call their cadence, their ability to walk in a normal time, can look entirely normal because it looks as though they've got a knee, because their ankle is now their knee joint. So this is what an x-ray will look like. It's very odd. So the fibula's on the wrong side, the tibia is now stuck to the femur, and the ankle is where the knee would be. And what they can do is you can have a prosthesis. This is a very rudimentary prosthesis. This is very early days. They get something a bit more sexy and sophisticated than that. But when that lad's trousers are down, when he walks without sticks. You wouldn't tell he's had an amputation because the knee is now the ankle, or the ankle is now the knee. And the bend through the ankle acts like a knee joint. The problem with an amputation, or the good things about an amputation if you like, it's very predictable. It is a once and for all operation. Some patients unfortunately need an amputation. The tumours are so big, or they've had inappropriate surgery elsewhere. We know actually an amputation is very expensive. So for that young man who I showed you the knee bending, or the ankle bending, sorry, that prosthesis is going to need to be changed very regularly because he will outgrow it or he will wear it out. As opposed to quite an expensive outlay to start with limb salvage, it might be expensive to start with, but over time, it's cost effective. And this is Amelia, because of course we have to show Amelia, because she's now sort of, I don't know, 13, 14. She's fantastic. You can't move for Good Morning Britain every few months, she's on there. But you'd never tell. And she loves taking you and showing her foot and showing it on the backwards, but you'd never tell. She'll go and dance. She's the most inspirational sort of character you can possibly meet. But you wouldn't tell that she's had a rotation-plasty. So as I say, some amputations allow good functional results. You can go to work with an amputation, of course you can. It's not quite as good in terms of limb salvage, of course. You can ski, but it is very expensive. This is one of our guys who's had an above knee, who was delivering the torch when, I don't know, was that London 2011, 2012? So just to put it all in perspective, so this is the largest sarcoma service in the Western world. Be proud of that. I am. I didn't leave here because I didn't enjoy working in Birmingham. Living in Birmingham is a bit different. But I left for various different reasons, but I was very pleased to come back. It is a great place to work. It's things like this that really reinforce that this is a great place to work, because we've got so many different colleagues from different parts of the hospital. Be very proud of the service we do, not just from tumours, spines I guess, but also hip and knees and upper limb and ankles. The job we do in oncology is extremely demanding. When the clinics are running over, our theatre's a little bit squiffy. Bear with us, it's not our fault sometimes, but it's very rewarding. Not only for the patients I look after, but I get to work with such awesome people as well. But it really boils down to, we've got to have some teamwork. As I say, I can show you some sexy pictures of surgery, but my job would be totally irrelevant if I didn't have you guys trying to help me. Is that okay? So I think that was a bit of a whistle-stop tour of the oncology service. Thank you very much.